very specific title, and it is a little important because of the subset of patients that we are going to see. So what we will see in the following 7 to 8 minutes, or let's say I'll try to finish in 7 minutes, is what is this dual mobility? How is it different to a conventional hip arthroplasty? What are the presumed benefits and advantages or disadvantages over conventional hip replacement? And what is the current status of the studies that are there? So if we all hip surgeons or arthroplasty surgeons are worried about anything, then apart from the aseptic loosening or the infection, the highest complication we are worried about is the dislocation. So if you look at these are the figures which are from the National Joint Registry of England and Wales, the latest report that has come out in 2023. So almost 15% of the complications are either because of dislocation, subluxation, or instability. If this goes on to a revision, then the dislocation is not the second common cause. It's the most common cause of failure of the joint is dislocation, and the percentage is very, very high. And as the revisions go on increase, the number of revisions go on increasing, this complications becomes the primary one. So dual mobilities are not new. Dual mobilities are quite old. It is a French design. Giles, Bosquet, and Rambert, they designed it first. This was the first generation of dual mobility cups. And what they thought about is that we use two basic principles in arthroplasty of a low friction, where there is a small femoral head which causes less wear, and there is a large head which basically gives you more stability. So it gets best of both the worlds in a single design. So that was the whole idea with which they designed the original dual mobility articulation. So what happens here in this diagram, if you see, on the left hand side is a conventional hip arthroplasty, and on the left hand side, on the other side is the dual mobility. So if you see the polyethylene insert, it is more than hemisphere. So it has to be more than a hemispherical cup so that will grab on to the smaller diameter of the femoral head. So the first articulation is between the metal femoral head onto the polyethylene articulation. And when that reaches the end of its movement, then the third articulation that comes in is between the neck of the femoral stem, which pushes the polyethylene further, and then that gives you the last range of movement which is there. And the larger head basically gives you a greater jump distance and more stable hip. So this in essence is the biomechanics. So this diagram shows you more clearly that the dual mobility comprises of an outer shell. This is the metallic shell. Then there is an inner polyliner, which is sort of more than a hemisphere. Then there is a metal head or the ceramic head currently we are using. And then there is the femoral sort of neck, which sort of also articulates along with the poly. So this is a clinical sort of image. Right, so this video is not working, but what this video would want to show is that as you put your hip through a range of movement, the bulk of the range of movement, the maximum movement occurs between the smaller diameter of the head and the plastic. And it is only when you push the head beyond its or the other hip, beyond its natural range of movement or in extremes of movement, that is when the poly actually moves. So this is how the dual mobility is supposed to function. Whether that functions well, we will see in the following slides. So obviously it has got benefits in patients with neuromuscular disease, cognitive dysfunction like Parkinsonism, patients who are very old, very high risk, you cannot afford another surgery, all the patients more than 75 years, especially if you are doing it for an intertrochanteric fracture or a fractured neck femur, revision scenarios, and previously failed trauma surgeries around the hip. However, our young patient does not have any of these. Okay, so the young patient with avascular necrosis does not fit into any of these criteria. So conventional hip arthroplasty, again, these videos may not work. Conventional hip arthroplasty also has given a good thing. Our patient characteristically is, let's say, a vegetable vendor or a manual worker or a daily worker in a factory or someone who's an occasional sports person, and they all get good range of movement. Most of them do well with a conventional hip replacement. Now, if you look at the National Joint Registry data and the graphs, this is a graph which is showing the cumulative risk of revision or failure. So this is cemented primary hip arthroplasty. So in here, the arrow points to the failure of the dual mobility articulation. So here you can see that the dual mobility articulation actually failing earlier and faster at a higher rate than even the metal on metal or large diameter resurfacing hip arthroplasties. But there is a caveat here, which we will see later on. If you compare hybrid primary replacements, then the dual mobility articulations do well. And if you see the uncemented primary hip replacements, then the dual mobility performs even better than the ceramic on ceramic hip replacements. So we can see that this is a very busy graph, but what it essentially shows on the left-hand side of the screen is elective hip replacements done for like primary pathologies of the hip, and on the other side it's hip replacements done for trauma. You can see the number of hip replacements is rising, but the bottom graph is the proportion of dual mobility in hip replacement is steadily going on increasing. So what is happening since 2013 is that the use of dual mobility hip replacements is going on increasing. But if you look at the different colored graphs, so what they have divided is that how many surgeries is done that particular surgeon doing. So if you look at it very carefully on the extreme last graph in 2022, you see that most of the hip replacements are done by low volume surgeons. So what this tells us is that the low volume surgeons are the ones who are tending to use dual mobility more than the people who are high volume surgeons. So possibly high volume surgeons are not yet sold to the idea, or they might be comfortable with a conventional hip arthroplasty, and the numbers of conventional hip arthroplasty far outnumber the dual mobility, and the proportion of dual mobility in their practice is much lower as compared to a low volume surgeon. If you see the trend, you see there is a growing acceptance of sort of dual mobility articulation because of its benefits regarding dislocation, better dislocation rates and giving stability, especially in the younger and more active patients. What confuses them, however, is that across all the joint registry it is shown that the risk of dislocation anyways is less using a conventional hip arthroplasty. Those conventional hip arthroplasties are anyways doing better, but still people and surgeons are opting for dual mobility articulation, possibly because they feel that it is a little safer. They feel a little reassured that, my hip is not going to dislocate, and we are going to have something like a constraint against any dislocation or any problems. So what is the problem? Why don't we use dual mobility as a default in all our young patients? There was a possibility that they could be loose earlier. There was a chance of early significant wear. Adverse reaction to metal debris was there. There was a high rate of intraprosthetic dislocation. However, all these complications were there in the original dual mobility design or the previous designs. So what has happened, and what has happened in the third generation or the newer generation, is that we have got a better taper of the femoral stem that articulates very well. So that is not rough, that is not circular, that is sort of flat. So that articulates better. The poly which you see in the dual mobility articulation, that is also beveled, that is not a sharp edge now. The femoral head do not have a skirt. In fact, the femoral head also have a bevel. So therefore, there is less chance of impingement over there. If there is impingement at the place which shows number 3, if there is impingement over there, over a period of time that will wear out and the head can dislocate from within the poly. Especially if there is arthropfibrosis and there is stiffness of the joint, then it can dislocate, and that is called as an intraprosthetic dislocation. So these changes have been made in the design so that there is no intraprosthetic dislocation. The hydroxyapatite coating is better, metallurgy is better, and now we also have an option to put the screws so that you can be reassured that it will be better. So is it for all the young arthritics? Now I bring your attention to this paper from Rajesh Malhotra from AIIMS, where they have sort of looked at the spinopelvic mobility in younger patients. So the interesting thing that they look at the sacral slope. If the patient is a very stiff hip, or if the patient has a very stiff spine, then you use a dual mobility articulation. If the patient is sort of stuck standing, so when we stand, the pelvis tilts posteriorly, and when we sit, the pelvis tilts a little anteriorly. So pelvis opens up and allows for the impingement or the neck to sort of get that extra range. But if the patient has got a lumbar-pelvic fusion or an arthritic spine and he's stuck standing, that is when you use a dual mobility articulation to prevent a dislocation. Otherwise, there is no indication of using a dual mobility articulation. So all in all, what do the studies say? The study says there is concern regarding wear. There is concern that we do not have long-term published data. The longest papers are about 10 to 12 years. And the third generation dual mobility articulations are better, and they are getting better. So in all, this supraphysiologic range of movement makes it a little forgiving procedure, and therefore it can leave a little room for imprecision. Like, your angles of safe zones, inclination angles, they can be a little, sort of extended. It permits a better reproduction of the native sort of biomechanics of the femoral head. But however, just be aware that because of the large head, there can be issues with iliopsoas impingement, anterior hip pain, and things like that. And currently, the wear characteristic of the dual mobility articulation are supposed to be better than even ceramic on ceramic or a ceramic on poly articulation. Yeah, so all in all, what we don't know is that what is going to happen in the long term. The French studies and the results from the French may not necessarily be repeated or duplicated, and newer modalities, newer cups are getting better, but we still need to wait and watch whether they will outperform their previous generation, and we can use a dual mobility for everyone. So right now, I think the take-home message would be, it's not for the young AVN, except if the young AVN patient has got some issues with his spine. It's a very stiff hip. So just make sure you individualize your approach, individualize the risk of dislocation that the patient has, and then only choose the implant. Thank you.